Our next speaker is Professor Carla Pugh. She's a professor of surgery at Stanford University School of Medicine. She's also the director of Technology-Enabled Clinical Improvement Center. She has received a lot of awards, but most prominently, she received the Early Career Award from President Obama in 2011. She's also a SAGES leader, and she's an upcoming leader that will be seeing a lot of her. That's what I would predict. Dr. Pugh is going to talk to us about reimagining surgical training.
So thank you very much, everyone. This is very exciting. When I think about reimagining surgical training, it gives me an opportunity as a surgeon and an educator and a researcher to pause and think about where we are now compared to where we could be. And instead of me going too futuristic, I really want to base it on where we could be given the technologies that are currently being developed by industry, by researchers, and are already in use or in some early stage of development. In order to do that, again, I'm going to juxtapose where we could be with surgical training now. Obviously a broad topic, I'm going to focus on 3 areas. So our apprentice model and what that really means in terms of how we're training our residents right now, and even some of our continuing education courses. Our curricular framework, which largely is focused on taking care of the surgical patient, hence our technical skills. And then I'm going broader in terms of just information exchange. How do our residents, how do our colleagues, practicing clinicians who want to learn a new procedure, how are they getting this information? And SAGES really has played a major role in advancing both national courses and online videos. And so this is the framework of my entire presentation and how I reimagine surgical training. So the apprentice model. The lens that really helps think about how we reimagine that gold standard framework for surgery is the flipped classroom. We've all heard of it, but really taking the time to think about how that layers on in the surgical profession. So for those of you who haven't heard about the flipped classroom model, which is really K through 12 and college education, the flipped classroom is a comparison of sorts and a framework where you look at the traditional training in a classroom and you have students who are passively taking in knowledge by an instructor. And then after that experience in the classroom with their fellow learners and students, then they go home and they do pre-assigned homework activity. The flipped classroom allows the students to then listen to the lecture ahead of time at home. And then when they come into the classroom, the teacher serves more of a coach, more as a director, and there is also peer-to-peer learning. And in those opportunities, there's active learning that's more personalized, because you're partnered with someone who looked at the lecture and interpreted one way, and then someone else interpreted another way. So how do we then make that framework for learning in the operating room, for example? So our traditional mode of learning in the operating room right now is, similar to the lecture and the knowledgeable person and everyone looking on, that's time spent observing in the operating room, and then homework is really whatever time the residents have to then do self-directed learning and based on their own self-assessment of their learning needs. So that is traditional surgical training. Observing the OR, then going to read about it or watch videos. The flipped version, in my mind, and again, based on things that are readily available today, is that you would spend time reviewing AI-enabled performance feedback on your cell phone or on a computer, and then by the time you get to the OR, You are then doing goal-directed or goal-oriented OR learning based on, again, what you pick. You're negotiating with your faculty person at the scrub desk. Like, these are the 4 procedures that I've done before in this area, and then you hone in. These are the parts I've done independently already. These are the ones that I want to do, or at least try to do today. And then that information is readily available on a computer screen in the OR. This is what I reimagine in terms of moving forward on the Apprentice model. Again, this is not something that's too far off. There are a number of companies, I don't list them all here, there are a number of companies that have begun building the infrastructure for this to happen right now. People are trying to use this in this way. What's really exciting is that the American Board of Surgery, under the leadership of Dr. Aurora Pryor, which is really exciting, is partnering with these 3 groups to sort of build this framework. How do we get there, not only obviously for training, but for the practicing clinician? So let's move on again to the next area, the curricular framework, which again, I say is largely focused on the care of the surgical patient and the technical skills. So when I reimagine that, looking at that now, again, it's focused on time in the operating room, obviously picking the right patient, learning how to take care of them postoperatively, and then getting, more independence in a stepwise fashion as you progress through your training. What's really an interesting lens is to think about competency-based education. A lot of us have talked about this from a number of different perspectives and use a number of different tools to get there, but just at a high level, the traditional model of education is really a preformed curriculum that you have, and you have educational objectives that are preformed, and you have an assessment. And these are just delivered, and this is the structure. And we still are largely in this phase. We have done a lot of work to go towards a competency-based education model. We're really focusing on what are the bigger needs. We're really focusing on the competencies of our clinicians and practitioners and the outcomes of our patients. And so when we start to look at that, then we can build a curriculum that is specific and more focused on the deficiencies in these areas. And the assessments are built on that as well. So as opposed to a preformed assessment that really then gets you more declarative knowledge or what we think you should be doing in the OR, but it's not fully linked to patient outcomes, that is really sort of the core of competency-based education. And when I think about the future and reimagining training from this perspective, this is sort of one lens that we could use. Another way of describing it in terms of traditional and competency-based and layering this on for surgical training is that instead of having case numbers, and we all talk about this, advancement by case numbers or certification based on case numbers, it's really based on performance outcomes. How are you performing? Are you proficient in these areas? And then which ones do you need to focus on? Instead of preformed educational objectives, again, it's competencies, as I mentioned, curriculum-based, competency-based, program-centric, learner-centric. And I think really this learner-centric will be enabled when we have the data to partner with the residents to enable them to be independent adult learners. And we're looking at them, haven't seen you in 3 months, you've been on colorectal and all of these other rotations. Now let's see where you are and how I can get you to the next level efficiently based on data. And then similarly, program completion, we talk about it, and we did toy, at a national level, a number of committees and folks at the board with reimagining the residency and maybe people finishing early if they had that clinical and technical acumen. But we had to step back a little bit because we realized we still didn't have the right assessments to really say that people were reaching where we wanted them to be. The other part of that is that we also definitely don't have the assessments right now in terms of holistic leaders. We're not just craftsmen in the OR who can, suture quickly and have great outcomes. You've got to be a leader. You've got to run that OR team. You've got to be efficient. You have to understand the surgical enterprise. And so if there are residents that are just swimming and they're just awesome, Jedi masters and their technical approach, 9 times out of 10, they still need some work on the leadership and the holistic side. And so with that sort of framework, how do you reimagine the curriculum? Again, if the residents are just nailing it in terms of, their operative skills and how they take care of their patients, communicate with families. There's always more work to do on the leadership side, self-awareness, communication skills, team skills, and the future is having assessments that really enable us to get to that holistic surgeon that we really desire. So moving on to information exchange, thinking about online videos, online information, national courses, and again, it's just exciting to be here and really celebrate all that SAGES has accomplished in this space. When we think about the resources that we have, you think about when you are preparing for a case in the OR, the classic resident, and even those that aren't involved in SAGES or even a surgeon who is, we still go to Google, for example, and you may, Google use of a specific type of stapler for a right hemicolectomy, and you start with, the search all, and you may get, 60,000 results. Most of them are going to be industry ads, and you can tell right away if you start pinprinting, you start to see, what they're talking about, and then a few of them are scientific papers. I think what's really interesting, there are a number of papers that show that almost 80% of surgeons will do a Google search or look for YouTube videos to get information. It's not perfect. So then you want to be more specific. Okay, I really want a video. I want to see someone using this stapler in this type of patient with this BMI. You search for videos, and instead of getting 62,000, you're down to 500, you're down to 600 results. And again, more industry, you can tell the 2-minute videos are advertisements. That's not what you're looking for. And then the YouTube videos, and this is another plug for SAGES and all the work that you all have done here. When you go to YouTube and you see a bunch of videos there, I can tell you, I do, and everyone else, a number of people that know about all the work that SAGES has done, you look for the videos that are by SAGES, that are produced by SAGES, because some of the other videos, I'll just put it out there, our colleagues aren't afraid of posting anything and putting it to classical music, and you can learn from those as well. But if you want to get quick information that you know is going to be good and on point, you're looking for those SAGES videos. I think when you start to think about then where could we be, it really relates to what are the other metadata variables that you want. I want someone who does this, more efficiently. I want someone who has this history of patient outcomes or has this patient population, right? So many times you're looking at a video and you're like, okay, that's helpful, but my patient has a BMI of, 55, 60, and that one, that's a lean athlete. And so some of the things are not applicable in terms of what you're looking at. We all have heard about this at the meeting, and AI has gained significant popularity in terms of being a tool to look through those videos, add metadata, so that really increases our ability to be efficient in finding what we want and it being specific to what we're really looking for. A lot of the folks that are in this space are annotating operative videos with a variety and different layers of information in terms of intraoperative events, severity rating scales, other types of things, patient information. And when you reimagine this, moving from your Google search that is labor intensive to something in the future, you're getting that 10-second video clip. That's exactly what you want. That's how I reimagine it. And so thinking about the courses now, there are, a variety of courses, whether they're sim-based courses, animal, cadaver. The biggest benefit is access to experts. And that's the mainstay. This is not going away. One of the barriers is then adopting these strategies once you get home. The future that addresses many of these barriers is telementoring. And these are capabilities we have now. And then instead of having, that one mentor that you have at a course, you've got a number of mentors around the globe that can watch your procedure and give you some feedback. And then access to experts and adoption, these become less of a barrier. So we've sort of really reviewed these 3 areas, and I'll end with a little bit about, this is the Apprentice Model flipped, the future, the curriculum flipped, more holistic, information exchange, powered by AI and telementoring. Some of the work we're doing in our lab, we're adding digital tracking to video-based, synchronizing that with a number of different wearable technologies. Again, this is technology that's available, wasn't developed for surgeons, we're adopting it. Wearing some of these technologies in the operating room. This is my brain during an appendectomy with an intern, okay? The red hot areas are where the important anatomy are. The orange areas are where I'm explaining and talking them down from doing something or trying to explain other things. So this is an appendectomy. Cholecystectomy, same thing. The darkest areas are when you're dividing the most important anatomic structures. There's a pattern here. It's consistent. Think about combining all of those data streams to quantify mastery and then having that as a real end goal for surgical training. And then auto documentation, all the work we do in the OR, we should have that readily available. Ladies and gentlemen, in the end, mastery learning is focused on overt behaviors that can be observed and measured. And we now have the technology to do more measuring and to enable that technology to reimagine where we are from a training perspective. Thank you.